So when you suffer from a heart attack, this heart attack called an ST elevation myocardial infarction, which means complete blockage of an artery, which means the muscle of the heart suffers a great deal in what is called transmural. So when you get this ST elevation myocardial infarction, it comes with complications, whether that artery is treated, as in whether blood supply to the muscle of the heart is restored or not. And, the complications come from ischemia, cardiac ischemia, and some complications come from what is called reperfusion. Like when you open that artery, there are complications that would come with it. That's why when patients are successfully treated for a heart attack, for a myocardial infarction, for the ST elevation myocardial infarction, that is, if you successfully give thrombolytics or you take to the catheterization lab and you're able to secure that artery, you must admit them to intensive care unit the first 24 hours. This is because the first 24 hours are very critical. These patients can get electrical complications. And in layman language, or in simplified language, it's cardiac arrhythmias, abnormal heart rhythms. A few patients have gone into complete heart block after a heart attack, and we've had to put in a temporary pacemaker to support the heart until the myocardium gets better, and that function of the pacemaker function of the heart recovers fully. Some patients have gone. The other complications are called ventricular fibrillation, where the muscle of the heart is just fibrillating. And when there's ventricular fibrillating, that heart will just stop if those rhythms are not identified and treated. You can also get ventricular tachycardia. It's the same. The ventricle is going so fast and there's no time to fill up the myocardium, and you can go into cardiac arrest. Some patients can just go into sinus tachycardia, but the reason to admit these patients is to monitor for those dangerous rhythms and to treat them. There are some patients might need electrical cardioversion, whereby you use electricity to erase, to delete those abnormal rhythms. As I said, some will need pacemaker, temporary pacemaker, sometimes for 72 hours, sometimes for a whole week. Some patients will need chemical cardioversion in what is called amiodarone. You can give them an infusion. So the first 24 hours after a heart attack are very, very, very crucial, and your patient can actually lose their life. Things can get complicated, goes into cardiac arrest, go into a coma, needing ICU. But if these abnormal rhythms are identified in a good center where people know what they are doing, these things can be reversed. And, we've seen these complications happening a lot in this country. So being a cardiologist doesn't mean just treating the heart attack. There's also intensive monitoring of your patient that happens, at least, the first 24 hours. But then you also need to monitor for other complications called mechanical complications, whereby when that muscle of the heart doesn't get blood supply for some time, it starts to die. And when it dies, then you can get an artificial hole in the heart, what is called ventricular septal defect, where there's a hole connecting the two chambers, because the muscle in that area has died because of prolonged lack of blood supply and oxygen. So the mechanical complications are there, and they need to be monitored. So patients usually have to get an ECG many times, sometimes so many times at night. And then patients, they have to have an echocardiogram before discharge, just to see if this heart attack has affected the heart and how has it affected the heart. And subsequently, patients need to be monitored closely, as they will be on blood thinners indefinitely, and the blood thinners can make patients bleed. So there's so much work around a heart attack. suffering a heart attack. And we need to identify these things because they happen every day. Sometimes when you're in training, you think sometimes you're taken through these complications, and then you're like, oh, what are the chances? And then that night when you're on call, you actually get someone who post ST elevation myocardial infarction treatment. They go into ventricular tachycardia, ventricular fibrillation. They go into complete heart block. So these things really happen, and they're quite common. So you need to monitor your patients. Usually when patients are admitted to an ICU, they get what is called telemetry, which is continuous electrocardiogram monitoring in the monitor. So in the morning, usually when we're doing rounds as cardiologists, we go through that telemetry just to see whether there were any events. Sometimes these events are silent and nobody picks them, but when you go through that recording, because the machine will just record everything for you, so you just sift through them. You walk through those rhythms every morning. They're called telemetry rounds. You go through them and then see some patients, maybe they have ventricular tachycardia, but it wasn't sustained, meaning it didn't go on for more than 30 seconds, but small seconds. And if you notice that your patient developed an arrhythmia, then you need to be very watchful, because that arrhythmia can prolong, can become sustained, and then your patient can go into cardiac arrest. So that's very important to observe.